Thank you so much for that introduction. It is a pleasure to be here talking about something that I care a lot about. Let me just get my slides started. All right, so just briefly where I am at, so I'm at SRI International, which is a nonprofit research organization. It was founded by Stanford University in 1946, but then it became independent of Stanford and is now known just as SRI International. And it does a whole range of different topics in research. It's probably best known for some of the innovations that's come out of it, including the computer mouse and also the first virtual personal assistant, which was bought by Apple and became Siri on the iPhone. Now, as part of our group, we have a human sleep research program, and that's embedded in the Center for Health Sciences in the Biosciences Division. And we do a large amount of research sort of centered around sleep, looking a lot at women's health, so menopausal health and menstrual cycle health, also considering a lot about adolescent development. And those are those two consortia studies that was mentioned, where we are tracking adolescents as they go through the teenage years and understanding better their brain and sleep and other behaviors, as well as the development of insomnia disorder. And throughout our work, we have a sleep research lab, and so we like to go in deep look at exploration of sleep and the brain during sleep and see what's happening and what are the mechanisms, such as across the menstrual cycle or menopause. And we often consider brain-body interactions like the central nervous system interacting with the autonomic nervous system. Now, everybody there knows how important sleep is, and we understand that it's important for functioning across the body, for memory consolidation, mood, both positive and negative, emotion regulation. It's important for immune system, for the cardiovascular system. It really is important for every system you could think of, including hormone, the endocrine system. And I really like, as shown on the left, the concept of sleep health, which was put forward by Dr. Baisi a number of years ago, which it really shows the multidimensional aspects of sleep. So considering beyond sleep duration, it's also important to consider regularity of sleep, how satisfied somebody feels about their sleep, so their quality, also daytime alertness, what the night of sleep, how that has affected their daytime functioning. Timing, what time do they go to bed? What time do they wake up? What time do they get out of bed? And then sleep efficiency as well. So how much sleep are they actually getting? So I think having more of a global look on sleep health can be very informative when we're trying to understand it. Now, in our lab, and as part of my talk today, you'll see that we are using multiple ways of assessing sleep, going right from the self-report to asking from surveys or sleep diaries how people think they are sleeping, recording the polysomnography in the lab. And then our group has done a number of studies where we've taken advantage of consumer wearables and being able to study or record aspects of sleep that you can get from these wearables outside of the laboratory. So for many nights, such as across a month, or as you will see, across a menstrual cycle. So while they are, the measures are not what we can get from the in-lab polysomnography measures, they do provide some objective indicator of sleep. And our group has done a lot of work to see and to compare some of these wearables with our gold standard polysomnography to understand better, well, how do they work compared to our gold standard, and then also how do we implement those in research so we can be recording sleep from individuals when they're in their home environment better. Now let's think about the menstrual cycle. So we know a lot about sleep as a biological rhythm. It's important homeostatic components and important circadian components. Now, when we put that together with in females where they have the menstrual cycle, this is another biological rhythm. Although it's often only considered as, well, either people are having menses and then not having menses, and then considering it as it's the female reproductive system that enables them to cycle through and enable reproduction. But there is a lot more to that cycle than just absence or presence of menses and thinking about it as just a reproductive function. It really does interact widely with other systems, including the sleep-wake system. Now, just to go through it, though, when we think about the menstrual cycle, it's broadly grouped into two phases: the follicular phase, which is pre-ovulation, which happens on around about day 14, if you're thinking about a typical 28-day cycle. And then there's the post-ovulatory luteal phase. And these phases are divided by the ovulation because of the changes in the hormone environment that you see, where very much in the follicular phase, you have sort of a steady level of estrogen until just before ovulation, when estrogen peaks, and then that triggers the ovulation. Progesterone levels, shown in the dark purple here, is low across the follicular phase, and then of course it increases and is maintained during the luteal phase. Now, if there is not fertilization of the ovum, then both the estrogen levels and the progesterone levels decline, and that marks the onset of the next menses. And then you have your pituitary hormones, the FSH, follicle stimulating hormone, and luteinizing hormone, which are involved in that whole hypothalamic pituitary ovarian axis. You see this nice peak in luteinizing hormone just before ovulation happens, and that is an indicator of impending ovulation. And then, of course, if you are looking at the ovarian cycle, you can see how the one ovum is growing and then released and then implants into the uterus. And so you have your cycles if you consider what's going on in the uterus. Now, when we think about the menstrual cycle, there's changes that are happening because the body is preparing for potential pregnancy. So you have an increase in metabolic rate in the luteal phase. You can see changes in the heart rate and heart rate variability, and then also the hormonal influences on other organs. And this table is very extensive. It's just meant to indicate just how wide the effect is of potential effect of these menstrual cycle hormones is, especially with the steroid hormones, estrogen. The receptors are widely distributed. So there is the potential for estrogen to affect multiple systems. So when you think about the menstrual cycle, then we like to talk about it as a biological rhythm, and it does have the potential to influence physiology and function of the majority of organs in the body. Now, when we look at individuals, not everybody has a 28-day cycle. The how regular someone's cycle is can also vary a lot. It can be 23 days, it could be 35 days, it could be irregular. And then there are also individuals who may suffer from some menstrual-associated disorders. And so those are shown on the left, where you can have dysmenorrhea, which is very common. It's painful menstruation. And it starts in adolescence and carries on through the reproductive years. It can be in about 50%, but with a range in severity. So very severe in about 15% of women. And then there's also premenstrual syndrome, which really describes symptoms, particularly mood symptoms, that can start emerging in the late luteal phase, so before menses, and can be also very disruptive to quality of life, sometimes in the extreme form, so that somebody would be diagnosed with premenstrual dysphoric disorder, which really describes the severe premenstrual symptoms that are impacting quality of life. And this can happen for at least a week premenstrually. And then another menstrual-associated disorder that is also quite common is polycystic ovarian syndrome. This is associated with hormonal imbalance and irregular menstrual cycles, and is apparent in about 10% of the female population. Now, finally, thinking about the menstrual cycle, well, how do we study it? So it can be studied in a variety of different ways. It's been quite common that people would use a diary to ask, self-report when is menses, and then from that you can determine, sort of roughly estimate menstrual cycle phases. There's, of course, now a growing number of menstrual tracking apps that can be helpful. Also, we found very helpful in research too. And then the more sort of gold standard ones of confirming if someone has an ovulatory menstrual cycle, you can do the urine test to track when someone's got that LH surge indicating ovulation, and also do blood tests where you can measure the levels of the hormones to confirm what those levels are and if there's been an increase in progesterone in the luteal phase. Now, another factor that I will also bring into my talk, which is so important, is the life cycle viewpoint. So whether you're looking at individuals right after menarche, so in the teenage years where they're just developing menstrual cycles, whether you're looking in the reproductive window when the sort of the primary window of the 20s and 30s, or whether you're looking late 40s towards the approach of menopause when their individuals are still having menstrual cycles, but they start to change. They become more irregular and may not be ovulatory as frequently. And as they begin to become more irregular, then you get the onset of menopause, which is defined as being the time in life when there's been 1 year of no menstrual cycles. Now, as I said, there's estrogen receptors widely distributed throughout the body. So there is this potential for the reproductive hormones to influence multiple functions in the body. And same goes for sleep. So the menstrual cycle could affect sleep directly through its estrogen's receptors, for example, in brain regions controlling sleep and arousal. But it also could affect it indirectly through the changes in temperature that occur as a part of the menstrual cycle hormone changes. It also could indirectly affect sleep through disruptors such as menstrual pain. But then we also got to look at the flip side, because sleep can affect the menstrual cycle. So again, thinking of this concept of the biological rhythms, they are connected this way. So when there are extremes in sleep, say very irregular, or such as sleeping at different times of day, then this can also affect the cyclicity of the menstrual cycle. So what I'll go through today is a couple of sort of snippets of looking at both the menstrual cycle influences on sleep and how it affects, depending on what we're measuring, whether it's self-report or with a wearable or polysomnography, and then briefly just giving an example of how sleep can also influence the menstrual cycle, so the other way around, and then talking about sleep in individuals with dysmenorrhea or PMS and polycystic ovarian syndrome and what to look out for. So taking advantage of this data that's been collected from menstrual tracking apps, which just gives this phenomenal number of observations. So it's just in the millions where individuals are tracking their mood, behavior, and other vital signs. And in this way, these researchers took advantage of this massive data set to look at rhythms, so both menstrual rhythms, daily rhythms, weekly and seasonal rhythms. And here's just 2 examples of where, when they asked people to also just report how energized they felt or how exhausted they felt, that did show a menstrual cycle change. So around the time of the period, individuals were reporting feeling less energized, so more tired. And that was a bigger effect than, say, a weekly or a seasonal effect, and even a little bit bigger than the daily rhythm that you see. Whereas sleep duration, which was rather roughly assessed just based and just looking at sleep duration, number of hours of sleeping, like 6 hours or more or 6 hours or less, there was really not much of a menstrual rhythm at all. What you really see in this case for sleep duration is this weekly rhythm. And as we know, that makes a lot of sense to everybody, because weekdays versus weekends, you often see a change in sleep. So just because of social lives. Now, what about with tracking devices? So we have been doing a study over the last few years, where as part of that study, we gave individuals Oura rings to track their sleep and other behaviors across the menstrual cycle. And so this data was published from the first part of the data set. So from a group of individuals, they were young, reproductive stage, and they did not suffer from any menstrual problems, no PMS. They were all with reported regular menstrual cycles, and they wore the Oura ring across a menstrual cycle. And as shown here with the data, we saw this very clear increase in heart rate in the mid-luteal and late luteal phases. So these are the windows that we looked at. So this is compared to the menses and ovulation. You see this increase in heart rate. And you see this very clear increase in skin temperature, again, in the luteal phases relative to the other two phases of menses or peri-ovulation. And we know for a long time that body temperature is a very useful marker of menstrual cycles. So 100 years ago, people were using just an oral temperature measurement in the morning to track menstrual cycles, because you do see this increase after ovulation, thought to be due to the effects of progesterone there, increasing temperature. And so we were able to see that with the skin temperature tracking with the Oura Ring, it also can pick up this temperature change. Now, how about looking at sleep? Well, with the Oura Ring measures, we did not find any changes in any of these sleep measures. So no changes in the sleep efficiency, no changes in sleep time, sleep duration, no changes in the sleep onset latency or in the amount of wake time across the night in this group of individuals. And as I said in the last slide, this was a group of females who reported very regular menstrual cycles and no PMS symptoms, no painful menses. And so what we are seeing here is that in this case, there are not changes in these sleep measures as measured with an Oura Ring. Now, how about when we look at the in-lab studies with polysomnography? And there's been a number of studies, but I wanted to show this one by Dr. Driver from 1996, because it was such a foundational study of really looking very closely at changes in polysomnographic sleep across the menstrual cycle. And it was a small sample, 9 females, but they were studied every second night across the menstrual cycle in the sleep lab, which is very intense. And they showed very clearly here that there are no changes in sleep continuity measures of wake time, sleep efficiency, and no changes in slow wave sleep across this menstrual cycle. They did find a small increase in stage 2 sleep, and that's going to come up when I also talk about sleep spindles. And they found a trend for a lower percentage of REM sleep in the luteal phase. So now in my own work, I also have found, also looked at sleep in the phases of the menstrual cycle, but not as intensely as Dr. Driver did. So here's some data where it was looking at 2 phases, mid-follicular and mid-luteal phase in a larger group of 20 women. And I found, like Dr. Driver found, the small, just about 1%, but fairly consistent decrease in REM sleep in the luteal phase. And that was associated with a decrease in REM episode durations, which was also found by Dr. Driver. So the REM episodes were of shorter duration across the cycles of the night, but no differences in the non-REM episodes. When looking at correlations, so trying to understand, well, what could be involved in these changes, we see that there are correlations between progesterone and percentage REM sleep. So with higher progesterone levels, there was lower percentages of REM, and the same thing with estradiol. So both these hormones, that hormonal environment of the luteal phase could be influencing REM sleep, but also there's other changes such as shown here, the temperature changes, and what I showed with the Oura Ring, where you get this very nice increase in temperature in the luteal phase, and very tracks the decrease in REM sleep that you see in the luteal phase. So it might also be that in this slightly higher temperature environment, that could be an environment where it's less compatible with REM sleep, so you see this decrease. But we actually don't really know what is the mechanism for this. Another study looked at hormone dynamics and sleep, so not just looking at the absolute levels coincident with the recordings, but what they did was to see the slope of change of progesterone from the follicular phase to the luteal phase. And they found in this case, that there was an association with disturbance or wakefulness after sleep onset and a trend for awakenings, where the steeper the slope was, then the more wakefulness after sleep onset in the luteal phase. So signs of relationships between hormones and aspects of sleep or sleep disturbance. Now, when we look at our sleep spindles, which we know are predominantly in stage N2 sleep, the sleep spindle really is the clearest indicator of, really is the one aspect of sleep that is very sensitive to the menstrual cycle. So and this was shown also again by Dr. Driver, and then subsequently in some of my studies too, and those of others, where we see this very specific increase in spindle frequency activity in the luteal phase compared to the follicular phase. So it's very isolated to sleep spindles. So you see an increase in spindle frequency activity, which is associated with the increase in the number of sleep spindles in the luteal phase. And I'll say one last thing about this is that we also saw this increase in sleep spindles and sleep spindle activity in a group of women in the menopause transition who were still cycling. So they were still showing this increase in spindle frequency activity. Now, when we look at these effects, so whether you're looking at self-report or whether you're looking at the Oura Ring results or the polysomnography, sometimes there's a lot of variability in results, and that can be due to sample size, but it is also due to there's a lot of variability between individuals, and that is so important, and I think is becoming clearer as we look more and more into menstrual cycle effects on sleep, is that not everybody is affected in the same way, and that's important when considering whether individuals are reporting that their sleep is worsening around the menstrual cycle. So some individuals say that it isn't, and others do say that it is affected. And I really like this study by Dr. Van Rijn and Kistner, where they looked at trajectories of sleep quality. In this case, it was self-reported insomnia symptoms in a group of young individuals. And they had a large enough sample to track trajectories. And they found that there's some where there is this dotted line, there is no cyclic change in these reported insomnia symptoms. So they are a common sort of almost half the sample were not showing any changes in insomnia symptoms, whereas the other two were. There was one that was showing a mid-cycle increase, that was the about 25%. Showing more insomnia complaints around ovulation. And then there was the pattern that we often are sort of thinking about as being like perimenstrual or premenstrual as well. That's this dotted line where they would show this increase in symptoms, insomnia symptoms around the time of menses. So with these trajectories, then we can begin to see how important it is to look at the individual differences and understand that some people maybe do not notice any changes in their sleep quality as they go through the menstrual cycle, whereas for others, it's a clear fact that they are having more sleep disturbances at certain times. Age is another important factor. So this study took advantage of a large sample from the study of women across the nation and tracked relationships of the reproductive hormone levels and sleep in this group, looking at the percentage of individuals with trouble sleeping. And they had premenopausal and perimenopausal individuals. They were all in their 40s. And they found that for both groups, there is a higher increase. There is a change in with more people reporting trouble sleeping around the time of menses than at other times of the cycle. And it was worse in the perimenopausal group of individuals. So we now have grown our study sample of individuals using the Oura Ring, and we now are looking at a group of females, some of who are in the reproductive phase and some who are in the late reproductive or early menopausal transition. And so it's now larger than that sample of 26 young individuals that I showed, and tracking sleep variables across the menstrual cycle. we don't see we see some trends, but no significant changes in these measures based on the Oura ring. What we do see is similar to what we saw in the smaller group, is very clear other physiological changes. So the increase in skin temperature, this is in the mid-luteal and late luteal phase, an increase in heart rate, again in the luteal phase, and a drop in heart rate variability. And in these heart rate measures, we see that there is a difference between the reproductive or the younger group and the pre-perimenopausal group, who have lower heart rate variability. And this is to be expected because they're of an older age. But for the sleep measures, with these continuity measures, we're not seeing changes across the menstrual cycle. And this really reflects then when you think about it, that sleep is an essential function of our bodies and needs to be maintained, and is very well, sleep continuity at least, is very well maintained, despite these other physiological changes that are happening across the menstrual cycle. Now, circadian rhythms, it's always important to also look at that, not just aspects of sleep. And so a number of people have studied circadian rhythms in conditions where they can be controlling the factors that could be influencing rhythms, so such as with forced desynchrony or similar protocols. And Dr. Boivin did such a study, and in individuals across the 2 menstrual cycle phases, and found that there is a very clear change in amplitude of the core body temperature. So it's blunted in the luteal phase, but no difference in the timing of the temperature minimum, and no differences in the melatonin rhythm. So here is on the right is the melatonin rhythm in the 2 menstrual phases, so mid-follicular in the dark circles and mid-luteal in the open circles, no difference there. Whereas in the for core body temperature that was tracked, you see in the open circles, the luteal phase, there is a blunted temperature rhythm, which is particularly evident at night. And this was with a a multiple nap protocol across the night. Similarly, when I have seen in my studies where I haven't done these measurements under controlled conditions, so these are in the sleep lab or when the individuals were going about their daily activities, but again, you can pick up this very clear increase in temperature in the luteal phase, and sort of a blunted amplitude because of this lower drop at night in the luteal phase compared to the follicular phase. So in summary, we can see that sleep can change across the menstrual cycle in some, but not all individuals, particularly when we're looking at sleep quality. Age can maybe moderate some effects of the menstrual cycle on sleep. And when we look at the polysomnographic measures, most studies show that sleep continuity is stable across the cycle. But when we look at some aspects like REM sleep, that is, there is a small decrease in REM sleep in the luteal phase and a prominent increase in sleep spindles in the luteal phase. From the circadian side, we can see that the circadian body temperature rhythms are blunted, but phase is similar in follicular and luteal phases. Now, looking at the reverse effect of, well, can sleep affect menstrual cycles? As part of this large study that we've been using the Oura ring for, we did also have the individuals complete diaries. And this was an analysis done by our partners in the study at UC Irvine. So Dr. Schuster led this analysis from UC Irvine, where she tracked the diary reported measures of positive mood and sleep quality, and wanted to see how they related to each other. And what she showed was that good sleep boosts positive mood. So good sleep predicted the next day's positive mood, regardless of menstrual cycle phase. And then there was an interaction with cycle phase in that poor sleep would lead to a lower positive mood during menses, more so than during non-menses. So in the context of the menstrual cycle, if the individuals were having a poorer sleep, then that would lead to a lower positive mood. But there was no effects on negative mood or interactions in this sample. Now, we often think as well, when looking at sleep effects on menstrual cycle, shift work often comes up. And again, others have looked at this and found that there is, in those both with short sleep duration and also those who are shift workers, there can be some irregular menstrual cycles, or less likely to have ovulatory menstrual cycles, subfertility in female shift workers, and also in those with extremely short sleep duration, less than 5 hours of sleep. So you get a higher risk of menstrual cycle irregularities and greater odds of menstrual disruption in shift workers who are rotating. So that's sort of very variable shift workers. And again, that makes sense in the context of thinking of the menstrual cycle as this strong biological rhythm, that if you are switching around any parts of behavior, such as the sleep-wake cycle, and that's that nice strong circadian rhythm, then it has the potential to influence the menstrual cycle rhythm. But when thinking about the sort of the conditions overall of shift work and maternal health or fertility health, meta-analyses have concluded that shift work poses minimal risk to the female reproductive system. So as things stand right now, shift work can increase risk for menstrual cycle disruption or pregnancy complications, but the research is very mixed, and these meta-analyses are showing that there is minimal risk overall for the female reproductive system. Now, in the final parts, I just want to turn to some of the menstrual-associated disorders, because what I've presented in terms of the menstrual cycle and sleep was looking at individuals who did not have any menstrual-associated complaints. So really looking at the undisturbed menstrual cycle. But when we consider the potential disturbances that individuals can have across the menstrual cycle, this could be associated with different parts of sleep being affected. So looking at sleep in women with severe menstrual pain or primary dysmenorrhea, this is one group that I've been particularly interested in. And there are a number of studies looking at their sleep, both from a self-reported standpoint and then also measured. And when looking at the summary, sort of a synthesis of the literature done by Dr. Unvar and colleagues, overall, those individuals with dysmenorrhea are likely to report a poorer sleep quality during menses compared to other times of their menstrual cycle. And some studies show that individuals with dysmenorrhea actually report a poorer sleep quality overall compared to individuals without dysmenorrhea. Depending, again, we often see there's sometimes such a variable way of asking about sleep. So studies have also looked at specifically insomnia symptoms, and those like the poorer sleep quality ratings, higher insomnia symptoms can be present during menses in the individuals with dysmenorrhea. I think there's just one study that showed that there was a shorter sleep duration during menses that was reported. And that goes along with the study that I did, where it was in a small sample, but we recorded the individuals with polysomnography during menses, and we found that they had a more fragmented sleep and a lower sleep efficiency. So they were waking up and moving more and having a very light sleep when they had the menstrual pain compared to other times of the menstrual cycle. And also important to look at the daytime aspects. So the sleepiness during the day, there are studies that have reported greater daytime sleepiness for individuals who have menstrual pain. Another study, and I'm sorry, this is the Unvar study. This was a study that looked at sort of a progressive severity of dysmenorrhea, so from mild, moderate, and severe, and looked at insomnia severity and sleep onset latency and awakenings during menses. And they found this graded response. So for insomnia severity, in association with increasing menstrual pain, there was an increase in the insomnia severity index scores, and also a lengthening in the time taken to fall asleep, sleep onset latency, and in the number of awakenings. So more severe pain, and then the more extensive were the sleep disturbances. Now, the good news is that we can address the menstrual pain, and in so doing could be improving sleep. And so this study was done by my colleague at University of Witwatersrand in Johannesburg, South Africa, where I still maintain connections with. And what they did in this study was to look at the effects of a non-steroidal anti-inflammatory that can be used to treat dysmenorrheic pain, so diclofenac potassium. And they did a placebo-controlled trial where they gave the individuals the active treatment during menses when they were suffering from pain, and they gave a placebo at another time when they were suffering from menstrual pain. And they also gave the diclofenac potassium during another time of the menstrual cycle when the individuals did not have any pain as well. And they found very clearly that when the individuals were taking the active medicine to treat their pain, then their sleep was better. So both their sleep quality was improved compared to when they had the placebo, so presumably untreated pain, ineffectively treated pain, and they also felt better in the morning, so higher morning vigilance. And when we looked at the polysomnographic measures of sleep efficiency, they had a better sleep efficiency when they were properly treated for their pain compared to the placebo. And there was no differences between the times when they were given the diclofenac potassium at a time of the menstrual cycle when they didn't have pain, showing that it itself did not influence sleep. It probably strongly suggests that by effectively treating the pain, they were able to sleep better that night. And now these are non-steroidal anti-inflammatory drugs are really recommended for treatment of menstrual pain. And here we show that they can be effective at improving sleep. Now, looking at PMS, so those individuals with severe premenstrual syndrome, which is another common menstrual associated disorder, we did a study in this group where we also brought them into the lab and we had them complete rating scales in the morning and also recorded their sleep. And we see that overall, the individuals with PMS, when they were having their symptoms in the late luteal phase, reported a poorer quality of life. They reported a higher amount of stress and more fatigue and a poorer mood, which is part of the PMS syndrome. We even found that regards to stress and fatigue, the individuals with PMS reported these symptoms when they were not even symptomatic for PMS, so even in the follicular phase. So there's some aspects that are state-based and some aspects that are trait-based, so different no matter when you measure them. And we found that the individuals with PMS reported a poorer sleep quality when they were symptomatic in the late luteal phase compared to their follicular phase, which led them to have a poorer sleep quality than the control group. But when we looked at the but I don't have that here. But when we looked at the PSG measures, we did not find there to be differences in sleep continuity measures. And we found that the subjective sleep quality was correlated with the anxiety levels. So higher anxiety levels were associated with poorer sleep quality ratings. What we did find in the polysomnographic measures was that the individuals with PMS actually had more slow wave sleep in both their phases compared to the controls, which is a finding that Dr. Boivin also showed in their studies. And they've linked that potentially to melatonin. And that's what is shown here. This is some of her results, where looking at individuals with PMS compared to controls, you can see that the individuals with mostly premenstrual dysphoric disorder in this case, so the more severe case, they have higher levels of slow wave sleep percentage in the follicular and luteal phase throughout really the menstrual cycle. And this was strongly correlated and associated with lower levels of melatonin. And that's led their group to hypothesize that there could be a link between the melatonin levels and the slow wave sleep. So they did a pilot study which showed that a melatonin supplement actually successfully reduced slow wave sleep and improved mood in the individuals with PMS. And along those same lines, Dr. Parry has done a number of studies looking at chronotherapies and whether they can be effective treatments in individuals with premenstrual dysphoric disorder, and found there to be efficacies both for light treatment and also selective sleep deprivation. So when we look at these two menstrual associated problems, dysmenorrhea and severe PMS or premenstrual dysphoric disorder, we can see that poor sleep quality and daytime sleepiness are apparent in the late luteal phase or during menses, which is when the individuals have these symptoms. For the cases of menstrual pain, analgesics that relieve menstrual pain are effective in restoring sleep quality. And when thinking about the links between pain and sleep, in the context of menstrual pain, it's also intriguing to think about whether sleep disturbances, if they go untreated, could contribute to central sensitization to pain in individuals with dysmenorrhea. So it could be really key to improve to treat their pain and improve their sleep. And also there is some work that suggests that insomnia symptoms over time can also lead to increases in dysmenorrhea. So again, bringing through loops between the reproductive cycle and its disturbances such as menstrual pain, sleep, and in this case, even pain. There is some work that suggests disturbed sleep homeostasis, so this higher level of slow wave sleep, and disturbed circadian rhythms, so lower melatonin secretion in premenstrual dysphoric disorder, which is leading to the investigation of chronotherapies and melatonin supplements as to find out whether those could target that mechanism. It is not yet, the research is not yet there to show whether melatonin supplements would be effective in the long term, and further work is needed since they're in the pilot stage of development. Now, just lastly, I just wanted to mention sleep and polycystic ovary syndrome, because this is a different kind of menstrual associated disorder from the PMS and the dysmenorrhea, but it is common with being experienced by about 10% of females. So it's a hormone disorder characterized by hyperandrogenism and irregular, absent, or anovulatory menstrual cycles, and it's strongly linked with insulin resistance, accompanied by insulin resistance and metabolic complications. And often you can also have obesity associated with PCOS. Now, given that framework of the symptoms and the experience in polycystic ovary syndrome, when you think about sleep, there is some evidence that these factors could be associated with obstructive sleep apnea, which is more common in individuals with PCOS. So this is really where the research has focused on, is looking at the prevalence of obstructive sleep apnea in individuals with PCOS. So there is this increased risk for PCOS. And so individuals with PCOS should be investigated for sleep apnea and treatment considered. Along with that sleep apnea, you can also see more fragmentation, sleep loss, and changes in their sleep composition. So in conclusion, we've gone through quite a lot of aspects of sleep and the menstrual cycle, and looking at both directions, we can see that the menstrual cycle can influence sleep quality in some individuals, but not all. We see that there is a sensitivity of sleep spindles in particular, which are increased in the luteal phase compared to the follicular phase. We also see that REM sleep is slightly reduced in the luteal phase compared to the follicular phase. Now, when we look at, think about sleep spindles, we know that they are important for memory consolidation. And so that leads to the next step of whether there is a functional relevance of this change in sleep spindles, or what effect does it have in this menstrual cycle context. And there is some research looking at that already. When we look at the other direction of can sleep influence the menstrual cycle, we can see that there is an association between sleep and mood, where poor sleep can lead to a lower level of positive mood in the menses. So sleep could be protective of mood. And in the cases, especially of individuals who are shift workers, the very short sleep and disrupted circadian rhythms can influence reproductive function. And now, in this whole context of looking at relationships between sleep and the menstrual cycle, again, it's so important to think about individuals, because there are some individuals that are sensitive to the menstrual cycle, and they may have menstrual associated disorders. There are some individuals that may be more sensitive to the changes of the hormones that are happening across the cycle in terms of their sleep sensitivity. And those are aspects, when trying to understand the individual experience, that we really need to understand and explore better. So I'll end there, and I'm happy to take questions. Just want to acknowledge my wonderful research lab here at SRI International, especially the research assistants who are responsible for collecting the data in our in-lab studies, where we are actively they have to stay awake at night and be recording these data. And thank you very much for your attention.